So you get a full blood count back, you look at the results, and bam, a high MCV. It can open up this huge kind of daunting range of possibilities. In the next few minutes, we're going to build a really simple but powerful framework to help you tackle macrocytic anemia with a lot more confidence. Let's get right into it.
But first, before we dive in, I really want to give credit where it's due. This entire high-yield explainer is based on the excellent source material provided by Dr. Mohammed El Nagi Mohammed. So what you're about to see is really his framework, just distilled for clinical practice and, of course, for exam success.
Okay, so here's our game plan. We'll start with the basic definition, then we'll hit the big one, the two main types, megaloblastic and normoblastic. We'll dig into the causes for each, and then we'll wrap it all up with the key takeaways you need to remember.
Right, first things first. Let's make sure we're all on the same page. What are we actually talking about when we say macrocytic anemia? Let's lock in that foundational definition.
Honestly, the clue is right there in the name. Macro means large, and cytic refers to the cell. So clinically, what this means is we're looking at anemia where the mean corpuscular volume, the MCV, is high. That tells us the red blood cells are abnormally large, and that one lab value, that's the trigger for this entire diagnostic framework we're building.
And now we've hit what is probably the single most important concept in this entire explainer. The whole diagnostic approach to macrocytic anemia splits into two very different paths. Understanding this fork in the road is absolutely the key to getting to the right diagnosis efficiently.
And that big distinction? It all comes down to the bone marrow. Is it megaloblastic? Meaning, are we seeing these huge immature red cell precursors because their development has been arrested? Or is it normoblastic, where the precursors are actually developing just fine? This one difference points to completely different underlying problems. So let's start by going down that megaloblastic path first.
Now pay attention to this subtitle here, impaired DNA synthesis. This is the whole story in a nutshell. For megaloblastic anemia, the fundamental problem is that the body can't make DNA properly. And this defect hits rapidly dividing cells the hardest, especially those hematopoietic cells in the bone marrow.
So what's messing with the DNA synthesis? Well, the two classic culprits are vitamin B12 and folate deficiency. And these aren't just any old vitamins, they are absolutely critical for making thymidine, which is a fundamental building block of DNA. If you don't have them, nuclear maturation just stalls out and you're left with those big, ineffective red cells that define this condition.
And here's a perfect real-world scenario that illustrates this. Methotrexate, a drug you see all the time in rheumatology and oncology, works by messing with folate metabolism. So as a direct consequence, it can cause a megaloblastic macrocytic anemia. This is one of those classic associations you just have to know for your exams.
Okay, so let's cross over to the other side of our framework. What if the bone marrow precursors are maturing normally, but the red cells floating around in the blood are still too big? Well, that brings us to the normoblastic causes, which you'll see is a much more diverse group.
And yeah, as you can see, the list of causes is pretty varied. You've got things like alcohol and chronic liver disease, which can actually change the lipids in the red cell membrane and make them bigger. Then you have something totally different like reticulocytosis. That's just an increase in young red cells, which are naturally larger anyway. Hypothyroidism can do it too, and of course, you have to consider more serious things like myelodysplastic syndrome. It's a very different set of mechanisms compared to that DNA synthesis problem we just talked about.
Phew! Okay, we've gone down both of those major pathways. Now let's bring it all back together and boil it down into a simple, memorable summary. This is the stuff you want right at your fingertips when you're on the wards or staring down an exam question.
And here it is, the entire framework in one shot. On the left, you've got megaloblastic. Think of it as a bone marrow factory problem, all rooted in faulty DNA synthesis, usually because of a B12 or folate deficiency. On the right, normoblastic. This is not a DNA synthesis issue. Instead, think about things like membrane problems from alcohol or liver disease, or maybe just a flood of those big young reticulocytes. This table, this is your high-yield summary.
So we'll end with a practical question for you. Now that you have this framework, when you see that next high MCV on a lab report, what's your first move? Well, you'd probably start by testing for the most common culprits in that megaloblastic pathway, right? Checking the B12 and folate levels. See, this framework isn't just about memorizing causes. It's about helping you think and helping you act.